introduction, okay?
Okay.
In 1 second. And as well, I'm going to record it as well to this computer.
I did have a few more updates that we may want to consider as well.
We'll go ahead.
Exciting.
So, okay, Amanda, go ahead and start. As well, I'm going to record it as well to this computer. Amanda, please, you can go ahead and start.
Hi, everybody. Thank you for joining. This is Essence of Medicine. Today, we're going to be talking about perioperative pain management. My name is Amanda Armagast.
I'm Dr. Abbasi.
My name is Alyssa Haber.
And Brian, you want to introduce yourself and what your expertise is here? Because you're going to be a big part of this conversation.
Brian Fleeman, Doctor of Nurse Anesthesiology Practice, Pain Fellowship, and Board Certified in Chronic Pain Management.
So you're all qualified to make the changes today. And this is actually, we are going to go over our current protocols and literally talk about medication, dosage, stage, that those are adequate to give. And everybody can ask questions. And we are going, at the end of this, we are going to have the updated version of our pain management protocols. So Alyssa, do you want to share the your screen and our current protocol? Now,
Absolutely.
the pain management is obviously going to be in stages. And if you can want to actually to increase the size.
Yep.
Okay, that's better. So the first stage of the pain management is actually when we talk to the patient in our office. We are not going to talk about that. That is something that we do. We talk about pain management. We tell them that you cannot have the surgery without having pain. This is just impossible.
Mm-hmm.
Some patients have been on narcotic for a long time. They are more of a problem during the perioperative time than the others. And we know as well that pain has a huge emotional risk aspect to that. It's lots of psychosocial issues are involved in that. Today, we are just going to talk about medication that we start just before or in the day or few days before the surgery. What we give right before the surgery, surgical pain management, it's all about medication. Now, right after the surgery, while patient is still in twilight, waking up from the anesthesia, medication that is right after the surgery in the PACU and during the hospital or ambulatory surgery center stay. Brian, before we start, I want you as well, tell us a little about, the group of patients, at least a little of your experience in this regard, and the group of the patient that you and I together have managed in Kansas. Do you want to give us a little, introduction about what we are going to talk about today?
Yeah, I've had 20 years of anesthesiology experience in Kansas. We are, in my practice, all the providers, we are heavily regional anesthesia providers, minimizing narcotics as much as possible using a multimodal analgesic approach as much as possible. And then in pain management, even in there, minimizing narcotic usage as much as possible. So I really believe in preemptive analgesia, where we can, block the pain receptors before the insult or injury occurs, has a much more profound effect on the patient, not letting them experience that pain and then having issues later with trying to catch up on that pain. So that's one of the things I'd like to talk about today.
Okay. Well, let's talk about the patient hits the door in the perioperative area. Obviously, we treat lots of patients with the back pain, leg pain, and many of these patients has been on long-term narcotic. Just about the perioperative area time before there are some thoughts about reducing the pain medication before the surgery. I have experienced that is many times is really not possible, Brian, that it is really hard to reduce their pain management. They are getting the surgery because they are in the pain, they are in severe pain. It's really very difficult to reduce their pain medication just before the surgery. And not many of them, but some of them have been even on methadone or some similar medication long term. Do you have any advice about, we are talking about now perioperative stage of the pain management. We obviously educate our patient, we give them acetaminophen. Gabapentin has been proven to be a good medication to give prior, and maybe some medication. Do you have any suggestion or changes you would like to make to that perioperative section of our, and Alyssa, if you can increase the size even a little more, then we can just concentrate on one stage at a time.
Okay.
I don't know if I can share, like half share my screen to get
Nope, that's it.
my changes on there too. I'm not as tech savvy as others.
Well, if you tell us, then Alyssa can type it as we go here.
Okay.
Yeah,
How's that?
yeah, that's good. That's good.
Let me get to my other screen here. Too many windows open now. And I don't know if I can find it. To answer your previous comment about reducing pain medicine prior to surgery, I think that's an absolutely horrible idea. As you mentioned, these patients, they're in chronic pain, and causing them more pain prior to going into surgery makes absolutely no sense to me whatsoever.
I agree with you.
So I would let them have their normal pain medicine as late as absolutely possible. Even if they're not the first patient in the day and they're not scheduled till 10 or 11, if they want to take their morning pain medication with clear liquids, that's completely okay too. The new ASA guidelines for NPO, nothing by mouth, they can have clear liquids up to 2 hours prior to anesthesia and surgery. There's some caveats to that, but we don't need to discuss all that here. The gram or 1,000 milligrams of Tylenol, I think, is a great adjunct. One of the things I like to do is give it in the IV form or Firmev and add 20 to 50 micrograms of dexmedetomidine. That's Precedex.
May I as well, Alyssa? Are you able to keep up with this, or
Do you want me to put this, write this down, or change it right away?
Well, let's just change it. Then we see the change, and then Brian and I, we can, or all of us, we can comment on that.
Absolutely.
Just let's just modify our protocol as we go. So.
Okay, you want to repeat that one more time if we use the IV?
Yeah, so the IV dose I think is better, because given the PO, you'd have to do probably 2 hours ahead of time to really stay within the guidelines for NPO. So IV, it's a little more expensive, but it's better. And then if depending on the patient's age and kind of health, and that's kind of an anesthesia, this will be an anesthesia thing to do 20 to 50 micrograms. Sorry, try not to talk in abbreviations too much. Precedex. C.
Thank you.
So, and then if you put that in the Firmev, which is the brand name for the acetaminophen, and just kind of run that in slowly over 30 minutes, Precedex has a amazing effect that it causes a similar state of sleep, but patient is completely responsive and arousable, and it is not amnestic like some of our other drugs we use, such as Versed, that actually cause you to have memory loss. And on our patient population, I think you'd agree, Dr. Bossi, that the 70 plus, they don't need to lose any more of their memory going into surgery and anesthesia.
So, and then Precedex, you can put it in a new line because that's obviously not the acetaminophen, please. So what is the, if you just shift tab, it's going to take it back to make it like number 3. Precedex should be number, yes, exactly. Now, what is the dosage of the Precedex you would recommend, Brian?
Again, just it's kind of, there is a microgram per kilogram dosage, but really a 50 microgram dose will be in somebody that's moderately healthy and doesn't have coexisting heart disease. 20 micrograms would be for elderly or someone that's got some cardiac history, because it can cause some bradycardia, but that's generally if you give it faster. So over 30 minutes diluted in the acetaminophen, it's really doesn't cause those problems. It's usually when you give it faster or in higher doses. The other benefit of Precedex is it is synergistic to every single other anesthesia or opioid medication we give, and has some pain blocking abilities in and of itself, but no respiratory depression side effects as some of our other pain medications have. Use this on almost every single anesthetic I give.
And this is before patient even goes to the OR. Is that?
That's correct. It should be at least 30 minutes before is ideal. After anesthesia sees the patient, if they start this medication even before the surgeon gets there, it's fine, because it's not an amnestic. It's just a very light, relaxation, just to help their nerves, but does not cause any memory impairment or any issues with signing consents and whatnot. But it's very, very helpful just to get them a little more relaxed, and makes everything else we give work that much better.
Now, preferably in most of the places that all the preoperative medication is given after patient has been consented already. But
yeah,
obviously patient has been consented in the clinic, but when they come, they sign the consent for, and Kim, that is important for you as well. In Summit, it's important that narcotics, sedatives, gabapentin is really not, doesn't influence that, but acetaminophen, neither acetaminophen, but anything that has any sedative effect or even narcotic should be given after patient already have signed the consent form.
And maybe I misspoke there, not necessarily signing consent, but sometimes, we wait until the surgeon sees them. But if the consents are signed and no questions.
Oh yeah, that is always include in the surgical ward, the consent signing, the consent always include patient and the surgeon talk.
Yeah.
And meaning that both surgeon and the patient have signed the day of the surgery the consent. Okay. So we can then add in the parentheses and so on that all narcotic and anything with a sedative effect should be given after patient and the surgeon had a chance to talk, and the consent has been signed by both.
Would you say all they should be given
after consent has been signed by both surgeon and patient, and they have talked? So any additional thing here, Brian, that you would, obviously this doesn't need to be the last time we are talking about that. So that, but I think that is a good start. A patient who has been on long-term narcotics, especially for them, I think we should be more. It will be obviously always a peer-to-peer decision between anesthesiologist and the surgeon. But especially people who have already been on long-term narcotic, I think this is a really good start for them to start this protocol even before the surgery.
This is Vanessa, and I'm sorry for the background noise, but we also had talked about some Zofran. I know nausea is not exactly pain, but it does increase pain. Yeah,
Decadron and Zofran can be done before or during the surgery, certainly as an adjunct. And then you can add 6, yes, Decadron and Zofran. Most of the time we do give as well Decadron for other reason, but Decadron and Zofran as an adjunct. Again, not pain medication. So today we are going to mostly talk about that, but doesn't hurt to have that as well in our protocol, that these are possible adjunct medication. Okay.
Just a quick comment on that. Anesthesia almost always gives Decadron and Zofran intraoperatively. So if we give it pre-op, there just needs to be communication so that we're not double dosing some of that.
And that is why I think, I would like to include them in the intraoperative and not perioperative area. Then it is under anesthesia supervision. So let's take it out, and then we can add that into intraoperative. Yes, exactly. Then the practically anesthesia is going to give that, and there's no miscommunication.
Yep, that's perfect. And again, communication, if patient's getting nauseous before, just contact anesthesia and we can take care of that.
Well, I remember that in few of my patients, even before the surgery, you did a rector spine block.
Correct.
So should we keep it before the surgery, perioperative, or for consideration, or during the surgery? What do you prefer?
I think preoperative is still best because we're
Okay.
putting in 0.25% marking. That's another thing that was on my list of
Yeah.
items to consider for preoperative.
Well, then we will right here consider a rector spine injection, because we know there's only so much medication you can give. And if we are going to do a very long stretch fusion and we are going to use a lot of local, that sort of put us at the so consider rector in co-op in peer-to-peer with the surgeon, so we know and we understand that we cannot go over a certain amount of consider a rector spine injection requires peer-to-peer between surgeon and anesthesiologist.
Correct. And again, it's 2.5 milligrams per kilogram is the maximum for marking bupivacaine. So generally we give 150 milligrams, which in an 80 kilogram patient would leave you another 50 milligrams of marking to give. But
should we write these things down that that
I have them written down on mine that I can forward, unless you want to put them on here now.
What you can do, you can put it in the chat box, and then Alyssa can just literally cut and paste. Alyssa, if you go to the chat box, you can just cut and paste that thing.
Sure.
And then we are done with our protocol. At the end of the meeting, we are done, and everybody knows what to do. If you have any additional question or input, it is the right time to include all inputs that everybody may have.
So I was just thinking just to take into consideration that if people are taking their pain meds, say they take Percocet before coming in, if it has Tylenol, does that matter?
Yes. We'll want to know that, because we'll either change our dose or not give that, and we'll just have to do something else. But yeah, we don't want to overdo their
So
dose.
we'll just add it to our checklist as far as asking the patient when they last took their pain meds, just so we don't go over on that.
Great catch. Yes.
Is it a patient of mine or okay? I'm in the middle of you. You still might be texting the name and the information. I will log in and look at it right after my meeting. Okay. Thank you. Bye.
Trying to move my.
So
chat.
sorry for that. Okay. Okay. So then I guess we can move on to the next step. Correct? Are you guys okay to move to intraoperative stage?
Yes.
Sure.
Okay. So. This has been all established over the last 10 years, has been very successful. Inject the skin with 1%. That says that's an I, not
I
one.
know. I just was seeing the same
1%
thing.
lidocaine with epinephrine and 0.25% marking plane, half, and then obviously at the end of the surgery we do two things. We do a lumbar epidural steroid injection, and as well, the 1 cc of marcaine is optional. So why don't you put that 1 cc of 25%? I'm sorry, 0.25 marcaine plane.
Yep.
That in parentheses and put optional. You can as well just put Kenalog in. That's fine.
Okay. Do you want the Kenalog optional as well? The whole thing.
No, Kenalog. Well. It's always, everything is optional. But if you are going to do Kenalog, you can add marcaine. Put in the parentheses, marcaine is optional. Okay. Because you can do as well epidural steroid injection without local anesthetic. And then we do two things. Either we do this 0.75 marcaine, or we do Exparel. And that is as well, the dealer's choice. And now there's few things. This is what surgeon does. Then obviously, in cooperation with anesthesia, we give 30 milligram of Toradol, ketamine, and then Decadron as well as actually anti-inflammatory effect. the dosage of the ketamine, Brian, do you have any suggestion or input regarding the dosage that we have here for ketamine or Toradol?
Yeah. Toradol, I mean, there's been a lot of studies that like 15 milligrams of Toradol is just as effective as 30. There's no difference the higher you go. And in anesthesia, because it is an anti-inflammatory, we try to get it at the very end of surgery, like after closure, give it and then extubate the patient, go to recovery room. So
Why don't we just add it at the end of the 15 to 30? Let's put 15 to 30 because at 30
Yep.
at the end of the surgery. But that is before patient leaves the OR.
Correct.
Well, obviously, you don't have to put that. Obviously, at the end of the surgery means before patient leaves, before the extubation. Okay. But okay, what else regarding ketamine, Brian?
Ketamine, a very common thing is we put 50 milligrams generally in a propofol syringe that we run because we're generally, if not always, doing neuromonitoring. So we use propofol. So we make a thing called ketafol. We put a little ketamine in the propofol and run that as in a slow infusion. And the ketamine is an exceptional pain medication, best given if there's some sedation prior to, because it can have some hallucinogenic effects that we don't want to cause preoperatively or postoperatively. But it's also an NMDA receptor antagonist and helps prevent central sensitization and other issues for chronic pain after that. So it's a great medication, especially patients that have been on a lot of narcotics that have tolerance. Ketamine works differently, so it's an excellent drug.
Yeah. Now I would take that propofol out there because it's per you. You guys decide that. So
okay.
And regarding the dosage, I heard that you go higher than 20 to 30. That's what I heard. So is it fair to say 20 to 50?
Yes.
Then dealer's choice?
Sure.
Okay, good. Zofran and Decadron. What would you suggest the dosage would be? I would say 4 to 8 for Zofran, probably Decadron 4 to 8. What do you think?
Yeah, generally we give 4 of Zofran. Decadron, we give 4 milligrams of Decadron generally too, but if sometimes it comes in a 10 milligram per mil and you just give 5 milligrams because it's easy to do.
Okay, but I often as well we give 8, up to 8. So I think if you put 4 to 8, that sort of covers it. Any suggestion?
Nope, that works.
Any of the team have any question regarding intraoperative phase?
The only other thing, and I would like to consider doing this, is using methadone for the intraoperative narcotic.
And then we can add maybe at 8, consider methadone. What dosage would you suggest?
20 milligrams. 20 milligrams and potentially, well, I would do that. And then people that have been on narcotics for a long time may need additional dosages, but we could consider that and doing that in the postoperative range.
Yeah.
The benefits of methadone, it works pretty quickly, 5 to 10 minutes onset, half-life 24 to 36 hours. So it creates a steady state of excellent pain control.
Yep.
For our patients. It also serotonin, epinephrine, reuptake inhibitor, NMDA receptor antagonist, in addition to ketamine. So there's a lot of benefits to that.
Sure. So should we write then here, consider methadone 20 milligram? Do you want to put another dosage there or just want to keep 20 milligram?
No, I keep it at 20 and then because they're going to be asleep, with induction, they're not going to need, they wouldn't necessarily need much more there.
Why don't we add here for long-term narcotic users or previously on methadone? Would that be fair to say?
Sure. But there's a lot of studies now they're doing it even for naive patients just to get a complete steady state and reduce
You want it for everyone?
Yeah,
Or consider for everyone.
Yeah.
Specifically are.
So just consider methadone 20 milligram, then that would cover it.
Sure.
Okay, Brian, or anybody else, any questions regarding the intraoperative phase? Then let's move to post-operative phase. Now, I'm going to tell what our protocols are. Everybody gets a muscle relaxant scheduled. And please put on that thing, you take that PRN out of Flexeril. And everybody gets, obviously, Visceral or hydroxyzine as well scheduled. And this should be, and I see that again and again, for some reason, people stop these two first. Whereas in my opinion, that should be the last thing should be stopped. This should be automatic, this should be scheduled. And that almost every study I've read, it reduces the requirement for the narcotic. So many patients as well who go home, we send them home with a schedule of that. And when they call me, they are in pain. They stopped the Visceral and Flexeril long time ago. And it wasn't, that is something, Alyssa, we have to communicate to our patient that these you take around the clock, and this is the last thing you stop. That we have to send them home. But let's talk about first post-operative stage. And then obviously all of them require an IV narcotic and a PO narcotic. And the IV narcotic is either for breakthrough or for if they cannot take PO.
Mhm.
Okay, so meaning that PO narcotic is always the preferred route. And obviously we do give Toradol. I used to give more 30s, but you're absolutely right, Brian. I have for last year or so, it's I usually go to 15, and that 15 milligram can be done IV or PO. Oh, we lost it.
I just lost my computer screen. I have no idea why. You keep going.
Well, you know, you try to bring it back up. And if not, tell me where it is, I bring it up. Tell me exact location of it and I bring
It's
it
in the
up.
drive. If you look up. I don't know what to do here.
Probably look up perioperative pain management and it'll pop right up.
Thank you.
Okay.
I can't access anything on my computer right now.
Come over here.
I might have to.
Okay, let me see what I can do here.
While we're looking through all that, just another note for communication between the anesthesia and even the PACU nurses. If we give Toradol right at the end of surgery prior to coming out, then we don't want to give that first dose again in PACU, but 6 hours later. So we just need to make sure that last dose of Toradol is documented and relayed to the PACU nurses if the patient's going to be there that long, or the inpatient nurses for patients that stay. So they know when to start that next dose again. And maybe we need a sheet that's separate that has our pain protocol and document things and times on that. So there's a clear communication from pre-op to anesthesia to PACU to the OR, to the floor nursing staff, so they don't have to go look through different, everybody has different mechanisms of charting, whether it's through the computer or paper or here or there. So things are easily missed. So if we have this protocol and the last dose of this written down, it's a good communication handoff tool.
That's a good idea.
Okay, so you got it back, Alyssa?
Well, I'm with Amanda now in the podcast room. My computer's still black. So
Okay. Is that the one?
yep. Updated and everything.
Okay. Then, so on our side, Brian, we have the Toradol, which we start before even patients wake up, obviously. We can use it PACU/OR. PACU/OR prior patient waking up. And obviously we have IV. I'm a big fan of hydromorphone. I'm not a big fan of, morphine or fentanyl. It's so short acting. After a few minutes or 10 minutes, you have to redose it. And obviously Norco or Percocet, and the dosages are there. Flexeril or Robaxin, Visceral, or something similar, hydroxyzine practically, gabapentin, and so on. So but we definitely need in the immediate post-operative phase, we need to consider as well ketamine. Brian, I really would love you to look at this, what's there, and tell us how we should modify it.
I think an excellent thing, and especially this is, going to be for our more our patients that are used to being on opioids. They're really hard to control with just other opioids, no matter what the dosage we give, because they just, the receptors they're just immune. They're just so tolerant of these. A concoction that I found works very, very effectively is mixing 200 milligrams of lidocaine with 3 grams. I'll slow down to.
No, you're okay.
3 grams of magnesium sulfate. And then, 25 to 50 milligrams of ketamine. And then infusing that over about 30 minutes.
Okay.
In PACU. And anesthesia should be involved in that too.
Yeah.
But if we get a patient over there and 5 minutes later they're awake and they're in more pain than they should be, this is an excellent way to kind of get things.
Good. Now, Alyssa, later on, put that at the bottom of the list and put it per anesthesia, or we can do it ourselves as well.
I will do that.
Yeah, later on you can just clean it up, please. Yeah,
Yep, absolutely.
obviously that include the ketamine, that include some other, the medication and so on, and that is a great idea.
It's just got a great benefit if even if they're awake enough to get PO, but they're hurting really bad, this is a great bridge till we get some of the PO medication on. And the only other thing post-operatively I consider is, doing the Norflex muscle relaxant IV if they're not awake enough yet to take PO.
Now, then we can add 11.
What was that called?
Norflex, Norflex. That's the brand name. It's orphanadrine. It's 60 milligrams IV. And it would be a one-time dose in PACU because you'd switch them over to the PO Flexeril after that. But it's just nice. And we may even want to consider doing as soon as they're awake in PACU, doing that too. So we can get that muscle relaxation on early. Because I agree totally that the muscle relaxants help with the pain quite a bit, even over the opioids. And
well, you poke it so many times in the paraspinal muscle that make total sense. And certainly, that is we have to as well later on come back and say which one of them automatically are going to be given and which one of them in a cooperation and discussion and so on and so forth. But I think we have a good understanding here that the muscle relaxant, hydroxyzine, narcotic, PO, and Toradol, this has been a good combination, at least in my practice. Anybody, any question or additional input here?
Yeah, this is Nicole from Summit. I have a question as far as the Norco and Percocet.
Okay.
How many tablets do you give of like the max dose?
Okay. Well, are you talking in the PACU or are you talking in the
hospital?
The hospital. Well, Norco or Percocet, obviously they have acetaminophen, and because of the acetaminophen, usually 1 to 2 tab every 4 hours is the absolute max I'm willing to give. I think acetaminophen maximal dose is, what is it? I think 1500 or 1700, Brian, what is the acetaminophen maximum dose per day?
Oh, like 3,000.
Oh, it is 3,000. Okay, so it's even more than I thought. So that means that you can almost give every 4, if we can calculate it and find out. But obviously with the Norco and Percocet, that is the limiting factor. Many times, please add to our number 3 as well, that oxy-IR should be considered, because then you're not limited by acetaminophen part of it. And oxy-IR, if patient has been on the narcotic before, you just reevaluate the patient, and you can go actually significantly higher if patient has developed some tolerance.
And that's one of the ways I'm advocating for doing a methadone interoperatively, because you should be able to take care of a significant amount of the pain for the first 24 hours with that, and then minimize some of this other the breakthrough medication you can still use, but it's going to dramatically reduce all these concerns of all these other PO medications.
Yeah. Number 3, could you as well put the maximum acetaminophen daily dose 3,000, please?
Oops.
3,000
Yes, sir. I just want to give you.
daily.
what I have.
Okay.
Here's the zeros.
Okay. Very good. So, are we all agreeing on this for now?
Yeah.
Now, obviously, the nurses who are going to use that in the PACU, they need to as well. Obviously, this is going to be we will talk about that and so on. But we should as well have those medications that automatically everybody will get, and those that we will talk to each other and start them as needed and so on. But if anybody has any additional input, it would be the right time.
I have a quick question. Number 2 right here. I don't know why they have all these eyes. What's this number supposed to be?
Well, it is IVQ 1 hour.
Okay, I
That's
figured.
one, but we can go actually significantly. Again, this is the dosage that it's, we can still get away and do different dosage, but that needs to be a conversation.
Sure.
Okay.
Well, I think that a big parenthesis or number 1 is, anesthesia should be completely in charge of the immediate postoperative care and making sure we get pain control of that patient and have some flexibility to give what they need to get caught up on that. So
yeah, be my guest, Brian. You can have a blaster. You can do, but
You wanna word that for me, Brian? I'm gonna put a little asterisk here.
just say anesthesia may modify medication and or dosages based on patient response.
Yeah.
Okay. Yep.
Just because I don't want to put limitations on, we can only do 0.6 milligrams of Dilaudid every 1 hour. If
Yeah.
patients have given 2 milligrams IV push immediately because I knew they could handle it, and I'm right there to handle.
This is just a protocol for, let's say, most of the patient.
Yeah.
Obviously, as provider, we have not only the right, but as well the obligation to modify it based on patient's needs. So it is nothing wrong to modify this as long as you are, the person who's going to be next to the patient, evaluate the patient, and so on. Then obviously that is going to be the case-by-case decision.
Sure.
Okay.
I just want to make sure that
Sure.
we're not trying to do this complete formula where there's a PACU nurse concerned about giving only this and not.
No, not at all. This is just letting the rest of the staff in the room, in the PACU, and in the facility know that we have a plan. Because last time we had a patient, and patient was in pain, and we have our protocol, and it just some people thought we don't have a plan, which it's not true. We have a plan. We will modify it as we go, and then adjust it to patient's need. Okay. So, Kim, any question regarding this so far?
So I'm just wondering, just to clarify, so on the ketamine cocktail, does anesthesia have to be with them then the whole time they're getting that infused?
Anesthesia will be, well, not with them, but they've got to be available. So they can't start that and then go home. So, but anesthesia to be there before they're discharged from PACU anyway. So,
But
Sure,
maybe we should add as well, just the option of just ketamine, okay, that one-time dose and so on, because that helped our last patient in the PACU significantly. If you are going to consider a one-time dose, I mean, I think 25 to 50 is a good one-time dose, and we can repeat it. What do you think? 20 minutes, half an hour? What do you think if we consider that? What should that be, Brian?
I'm not sure I would repeat that post-operative dose, because I think you get into a high enough dose where the patients are going to start having issues with potential hallucination and everything else. It's a great analgesic.
Oh, no, that is alternative to that 200 milligram of lidocaine, 3 gram magnesium, and so on. These are alternative paths, not both of them. But if for whatever reason we don't want to start a drip, for whatever reason, I think a one or two dose of ketamine should be considered as an alternative.
Sure.
Well, if that's the case, what should that be? 25 to 50 or?
Yes, that 25 to 50 is good. And I wouldn't probably repeat that one if anesthesia is not involved.
Okay.
How often?
So can I ask a question?
And PACU.
So Brian, okay, so say that we have a patient coming back in pain, we want to give that ketamine cocktail first thing. Okay, say we get it started on that. Can our anesthesia provider go in and start surgery then while the PACU nurse is monitoring?
Yeah, I mean, there's really very low risk with it.
Okay, so but I'm just saying, it sounds like it would be a first thing, good, almost first thing to give them.
I love taking patients over and just having that as a slow drip to begin with when they're breathing back and doing fine, because it's a great adjunct and keeps it makes them very, very happy. But
and that might be less narcotics that they would need then maybe too. Does it last a while?
Yes, because I mean, especially if you give what we did, perioperatively, intraoperatively, and then you're doing this, because none of magnesium, the lidocaine, and the ketamine, none of those cause respiratory depression, and they're great adjuncts to each other and the opioids that we give intraoperatively.
Which would be nice, because we do have to get our patients up. We'd like to get them up, kind of moving, so maybe this would help with that too, as far as not being, under so many narcotics, maybe.
Sure. So Kim, obviously we have to, after we are done today here, you need to send it to our anesthesiologists. If they are going to do that, they should have a saying in this as well. But once we are done, get a copy. Alyssa, send a copy to all of them.
Absolutely. And
then you forward this to our anesthesiologist. They had some birthday coming. They couldn't be here, but they should have as well, obviously, input on this. If they are going to do that, we should give them the courtesy of being part of this protocol. But
sure, I'll send it to her.
This is comprehensive enough. Any other input? Any other question here?
Do you want to go through outpatient?
No, first let's see if anybody else has an additional comment or question here. Brian, are you okay with this as it stands here?
Yes.
Good. Then let's go to discharge. Okay. So this is one of the things that has worked in my hand the best. I do send them home with 3 prescriptions. And not going to go to details of that, but it has been quite very efficiently to give them 3 prescriptions in the hand, paper prescription, because then there's no question. Did you get it? Was it sent? Wasn't it not sent? And so on and so forth. And believe it or not, paper prescription is valid everywhere. Okay. So, and obviously we send them home always with 3 prescriptions. Flexural or muscle relaxant, visceral. For that reason, I would put the visceral number 3, not number 4. So, and maybe even, we can change that as such that that maybe there are different color and so on, because this number 1, 2, 3 is automatically for everybody.
Yes, I agree.
Okay, then we can go to the other numbers like Lyrica. It's obviously effective. Physical therapy can be effective. Education is important. Even sometimes I send the patient home with Toradol, PO, okay, for 2 days, but not more than that. And also, Toradol has very little effect on the anticoagulation, if anything at all. And as well, in our surgery, we don't open the lamina. So we can as well now maybe add number 4 and 5, Toradol and Lyrica, considering Toradol and Lyrica. Now, as obviously, optional gabapentin, ESI, foraminal injection, and so on. These are as well some other options. And I think more importantly is the education of the patient is so important that when about 3 to 5 days after surgery, swelling gets worse, the pain gets worse, and the core education should remain the important part of this postoperative care. And I understand that you see the patient before the surgery, Alyssa, and you educate them about that. And you should create a video that they can watch, and that should be a required video to watch.
I can do that.
Okay. So anybody else? I know that this part is mostly us on the clinical side, is not the staff in the surgery center or hospital or anesthesia, but I still welcome any input or comment here.
So just to loop back around, are we going to create a form of this protocol and then like last dose, like a handoff sheet, so that things like the acetaminophen, if patient's already on that, they're not getting another 1,000 milligrams pre-op. Toradol, that they're not getting a second dose. And well, I guess if we're giving 15 and they give another 15, it's not the worst thing in the world. But I'm just, communication handoff sheet would be nice to what's the patient received so far, when's their next dose supposed to be.
Well,
Brian, we send that home with the patient. We write that down so that they know when to take their next dose as far as being maxed out on.
I was thinking more of the perioperative period, like between pre-op nursing, anesthesia.
Oh, we have to talk. That is not optional.
Yeah.
Everybody in the facility, we need to talk to each other, and we have to keep a medication that patient has gotten already. That needs to be a constant communication between everybody. And obviously, anesthesia is a big part of it. You guys are in peri. I agree with you. You will be in charge of the perioperative pain management, but the reason we are doing that is that everybody knows what we are doing, and believe it or not, some anesthesiologists or nurse anesthetists don't feel as comfortable as you feel about perioperative pain management. So it's going to be a constant peer-to-peer between the nurses, surgeon, and the anesthesiologist, but more or less, anesthesiologists should be in charge of the dosage and the medication.
Yeah, no, and I agree. Communication is great, but I also know there's a lot of times there's an intentional breakdown in communication verbally. Mm-hmm. If there's like a sheet that was a handoff sheet that went from pre-op through post-op to the inpatient unit of this is all the things we gave based on the protocol.
I see what you're saying. You make it easier instead of going and digging in the chart saying, when's the last time?
I've got to follow case and I have got to go to see them and I'm going to do a block and I forget to tell them I gave X. So they've got to figure out, or they get busy and they forget to look at my thing. If we have a sheet that we just mark while we're in surgery.
Just like a workflow sheet.
Yeah. Workflow sheet, pre-op all the way through inpatient. So there's a very clear thing. Did not receive acetaminophen pre-op because patients already taken their morning meds that had X. And then interoperatively, I gave 15 milligrams Toradol at the end of the case. So PACU nurses know they don't need to give. I mean, it wouldn't, again, that's probably not the best example because we're giving a lower dose.
I know, yeah.
But just so people don't have to dig through things or call and say, hey,
that's a great idea.
Got to do that. So, and it's a great tool for any surveyors or anything else. That's just great communication tool to show them that, we're trying to do the best thing for the patient by excellent communication, because we have this written protocol and we have this document that we go from.
Sounds great. Now, Sounds great. Could we create a form that all these medication are listed, and then we can just put the time and the dosage they are given from
Yes.
the moment the patient hit the door to the moment patient is, and then that can be in the front of patient's chart, literally a paper copy in front of the patient's chart, that nobody can miss it. Is that what you're asking, right?
Yeah,
Brian?
that's exactly right. And then on the preoperative thing, any patient medication they took that morning, because if they took an Norco or something or anything with acetaminophen in, and that would be the only other thing, and then everything else is perfect. And putting that on the front of the chart, I think, is a great communication tool and high value.
Then we should put all this medication on a list where in boxes in front of it, we can put the dosage and the time they are given. And that should be pretty much in front of the first thing you open the chart, that should be what you're seeing. And that sort of help us to create that sign off, or whatever method we want to call it, that everybody knows what's already given.
Yes.
Okay. Now, I think we are almost done here.
Yep.
Or does anybody has any additional input here?
I just had one more thought that just came to me.
Yeah.
I mean, what would be the benefit of putting like preoperative, intraoperative wouldn't matter, but preoperative, immediate postoperative, and then either before discharge or before going over to the inpatient unit pain scores. So we can kind of, if we're going to develop this sheet that says, this is our protocol, these are the medications we've given, kind of keeping track of pain scores, we can kind of fine tune what we're doing on our outcomes of, what patients tell us that they're.
We can add that to the same page that we have write the pain medication. We can add another thing that as well we score the pain and so on. Yeah, well, we should. But I thought that is a routine thing. We do it already. We always.
Yeah, but it's tracked differently. So like in pre-op would have it somewhere buried in their chart.
Yeah, that's
Anesthesia
right.
has it in a paper chart that's separate from their chart, depending on how those systems are incorporated. You're maybe completely different documenting these days. Even different EMRs within systems. I know of systems that have one EMR that they document on, and anesthesia documents on a completely different EMR, and they should communicate, but they don't.
Sure. Then I would suggest that same page that we record the pain medication, and let's put it in one page. If there are more than one page, it's going to be just more confusing. But one page where we track the medication it's given, as well as time and the pain score, then we can, that would be a good tool later on as well to see the effectiveness of the medication or variation of the medication given. It's a great idea. Any other input? Any other question?
And maybe next to the pain score, we could have them just put the new pain score after that's taken effect. We can do it every 15, 30 minutes, or just to see if that was effective, what they were given, maybe.
Yeah, well, if you make it too complex, I think that the compliance of the staff will fall down. We can try it and see if it works or not.
Okay.
I think just keeping a simple pain score.
Okay.
Initial pre-op pain score, initial PACU pain score when the patient's awake enough to answer, initial inpatient, they're admitted to inpatient unit, their initial pain score, or if they're going home, their pain score right before going home.
Yeah.
And
Okay.
people like that, because if you do too much of that, just like Dr. Presley said, it's going to be too much work, and people are going to be like,
Exactly.
Case,
No, I like that.
In our case, will be pre-admitting or pre-surgery score, right at the PACU score, when we move them from the PACU to the discharge unit, and then discharge. 4 pain score, more than enough.
Yep, sounds good. Perfect.
Okay, well, thank you, everybody. I think this was very productive. And if you have any question, please ask now. Otherwise, we will refine it, make it in a 1 page. And even if it will be small writing, please, Alyssa, make it 1 page, because if it's, again, more than 1 page, we cannot print it out and put it in places available to everybody. and then we will clean it up, get additional input, and then go from there.
Cool.
Sounds good.
Okay, thank you, everybody.
Thanks, guys.
Thank you.
Bye-bye.
Have a good weekend.
Dr. Bossi, do you have time to stay on or do you want me to call you? Do you have a minute?
Oh, yeah, we can, but this is being podcasted, so maybe
Oh,
we
just-
call.
okay.
Okay, thank you, Brian. Okay, bye-bye.
Bye-bye.